Assalamu alaikum. The patient came for pelvic pain and there is suspected right hydronephrosis by ultrasound. Already they diagnosed that there is right mild hydronephrosis and they ask to check by MRI. Also for the pelvic pain they suspect that there could be right ovarian cyst or adnexal cyst. So for that they request MRI. During while we check for MRI, we check for all the sequences. We find the cyst, the right adnexal cyst, and if you check for the cyst, we try to characterize the nature of the cyst. In the T2, it's right T2 signal. Maybe you can note some internal fine septi within. We go to check in diffusion, there is no diffusion restriction. And if you check for post contrast, you will find that there is no solid component or enhancing septi or any nodularity or any feature that could make you think that it could be suspicious or malignant features. When we go to check the right hydronephrosis, you will find that this patient have, yes, this hydronephrosis. I'm just to check for the best sequence to show to you. Yes, so there is right hydronephrosis, mild to moderate type, and if you check you'll find that there is abrupt change in the caliber here. So in this area you cannot find the site of the ureter that could be dilated. There is MRU done sequence and you can see that there is ballooning in the right renal pelvis and the calyceal system as well. And this abrupt change it reach here, and after that the ureter appear like intact. While I'm checking in the system, we find that this patient have also previous CT, and this CT was without contrast. Let me show you the CT. So they suspect firstly like that there could be stones and something that like that, but you cannot see any renal stones. So right now we gathering the information from MRI and CT that there is pelvi ureteric junction, could be dysfunction or obstruction here, and this could be the reason for right-sided mild to moderate hydronephrosis. And there is another lesion, cystic lesion, that could be incidental or the reason for pelvic pain. And we check if there is any signs of torsion or any complication that could happen for this patient. So until this point we try to figure out the reason for that. Again, the clinician for this patient, he sent the patient for reason again that he want to characterize this BOJ junction lesion, and as you can see we try to measure all the right hydronephrosis, and as well we try to characterize the lesion itself, if there is any change happen during this interval. While we check this case, we find something maybe interesting that we can show to you. This is the right renal artery, and here you can see that both renal artery arising from the aorta. and during you scroll down you find another, this accessory renal artery here. Yes, and if you go check in the coronal view, maybe I can try to collect all the images together, maybe like that. Okay, so during this you can see that there is something here. Yes, yes. And it passes in the side of the right BOJ, exactly here. So what I'm thinking in this right now, that the reason for this BOJ obstruction, so it could be the extrinsic vascular compression, and can make explanation for what we are seeing right now in this case. So this is the renal artery, and there is another accessory, so could be the reason for that this patient have like chronic. Let me show you more images. That this patient could have like chronic BOJ obstruction, and the reason for that could be the extrinsic compression from the right renal artery. Retrospectively, when I go to check the MRI again, let me show you something. Let's go to the MRU itself, what I show you before. Yes, so this was the one I showed you before. Maybe right now you will know something. Yes, here, exactly at the side of the external, the accessory renal artery. I would like to show you more images, if this could add something. Yes, here I think I have one coronal image as well. It can be of value, yes, in such case. So the final, yes, here you can see that it could be this, what we saw before as a vascular compression. So as a conclusion, this case, this could be the chronic BOJ in this case as a result of extrinsic compression of the artery. While checking the literature, I find like something maybe interesting, that there is a similar case in Radiopedia with BOJ obstruction by accessory renal vein. And if you go to the literature, you'll find like there is some interesting articles, like there is one in Urography as well about similar BOJ obstruction. Our case is like 13 years old. This patient is 10 years, so the same, I think, in the same age decade. There are many interesting cases while you check in literature talking about that, the reason for such. And this is called apparent renal artery, and here I think is very similar to our case with this good illustration. And already I show you yes, our case. It look interesting, so I'd like just to share with you if this could be the reason for what this patient have. Sometimes some cases in the start it can look like easy case and just you spot, but when you go in deep analysis, I think it's better idea to to check everything and to go again and again to the clinical data of the patient. Sometimes you can get answer for what you see. And thank you.